Morning, Dr. Beck. Can you hear me? All right. So, there it is. It should work. Hi, Sam. How are you doing? Looks like your microphone's off, so you might need to
Hi.
click on. Hi.
Hi, can
All
you hear
right.
me?
Yes.
Great.
Okay.
How are you?
Good. How are you?
Good.
Good. Awesome. Excited about this webinar.
We are too.
Let's see. One second. Okay. Let's see who else is here. Will I be able to see participants? One second.
Dr. Beck, are you in New York?
No, he's from Newport Beach. Well, he was from New York, yes.
Oh, okay.
Yeah, he worked at the IVF that falls under Columbia University before he moved to HRC Newport Beach.
Okay.
Yeah. Okay. I think we're really lining up. We have a good amount of participant. We're just gonna get started. Dr. Beck, can you hear us? I can hear her background noise, but I don't
Yeah,
think she.
I don't think she can hear us.
Okay. No. Okay. See what else.
She said she can't hear us.
Yeah, because the microphone's her microphone's
Hear
on.
me, everyone?
Oh, okay.
Yeah,
Now we
yeah,
can.
you're on now. Okay. Okay. All right, Dr. Beck. Again,
Okay, great. I think we're just waiting for the introduction from Patriots Conceptions to start.
Absolutely. Good morning, everyone. I think we got a good amount of participants. Thanks for joining us today for this online webinar event. Joining us together with the HRC Fertility and the GSRC relationship consultants from the East Coast. Dr. Lisa Beck, she's the anchor doctor from HRC Newport Beach, and she's been practicing for decades from Columbia University. And we also have Dr. Samantha Levy and Dr. Jens Storm from the GSRC. They will be talking to us about the psychological challenges and how to cope with them during the surrogacy journey. So without further ado, I think the first part is Dr. Let's see. Okay, sorry. I'm sorry. That's the introduction slide. And in this webinar, we'll be going over a few topics. First of all, it's the pandemic. It's the COVID-19. The do's and don'ts. The safety measures that we impose at the clinic and at our workplaces. How that would affect our journey. Dr. Lisa Beck will explain in vitro fertilization treatment to us in depth. I will also explain the surrogacy, especially the screening and matching process in detail. And the GSRC group will be talking about the psychological part, especially how the therapy supports IPs, and the surrogates during this webinar. And at the end of the webinar, we will hold a brief Q&A section. Okay, Dr. Beck, this is your part now.
Hi, everyone. My name is Dr. Lisa Beck. I'm a double board certified reproductive endocrinology and infertility doctor, which is also called a fertility specialist. I work here at HRC in Newport Beach and Laguna Hills as my main offices. And I'm really excited to be speaking to you all today a little bit more about in vitro fertilization and surrogacy, especially in this time of COVID-19. So just to talk to you a little bit about IVF, in vitro fertilization is basically the way that we're going to bring eggs and sperm together to basically make what we call a test tube baby. And by doing that, we can really maximize success and really offer many different options to people. So first of all, when we do IVF, we'll go through the whole process in just a little bit. But the first thing is that really we can use different eggs. So whether that's using your egg or potentially using an egg donor, that is an option when we do IVF. And then in terms of combining that with sperm, you can see on this picture over on the right-hand side of the screen, that's called ICSI, which is when we literally put the sperm in the egg. And so by doing all of this, we maximize the chance that an egg and sperm combine. And then by growing embryos in our laboratory, we're able to watch them and get you more information. And then the last part of it that we really do nowadays is genetic testing, which again, we'll talk all about it in a few minutes. But by doing that, we're really maximizing success rates. Here at HRC, we have the highest rates on the West Coast. It's about a 75% plus chance of pregnancy per transfer. And so really IVF is really, from all of this technology, really maximizing success. And then most importantly, when we're talking about using a surrogate, we then have this embryo that we can then transfer into the surrogate. So just to talk a little bit more specifically in detail about the IVF process. So basically IVF is trying to increase the number of eggs that we can use in a month to maximize success. Typically a woman just naturally has her one egg that's going to ovulate each month, but there's other little eggs in the ovary that unfortunately go away at the end of the month. And so with IVF, we're having you do injections to try to stimulate all of the eggs that you have available so that they can grow and then be used. The first misconception sometimes people have is, unfortunately, we can't give you more eggs that you don't have. We can only use the ones that you do have, but this is where the stimulation comes into play to try to just maximize what your ovary can produce. Or if we're not using your ovary, it would be with your egg donors. And so those stimulations, they usually go on for about 10 to 12 days. The injections themselves, I would say that's usually the part people are most scared about when thinking about IVF, but we teach you or your egg donor how to do that. And the needle is a very small insulin needle that basically goes either in your belly or thigh. And those injections, as you continue to take them, is going to get hopefully your eggs to grow. And we can see that on ultrasound, which is called a follicle, which is at the very bottom left of the screen. And so by going through about those 10 to 12 days of injections, during that time you're coming for ultrasounds and blood work, basically to monitor how those eggs are doing. And at the end of all of that, when they're hopefully nice, big, and ready, you take a special trigger shot, which is going to get the eggs ready to come out, followed by the egg retrieval procedure. We do that under sedation anesthesia, so like twilight, meaning that you do get to go to sleep during it. It's an IV in your arm. It's not a full breathing tube or muscle paralysis or anything like that. So it's a very quick on and off. The procedure is about 10 to 15 minutes, depending on how many eggs you have. You wake right back up and you literally go home about an hour later. That day of the procedure, definitely you'd want to take off just more from the anesthesia. But after that, really at the end of this, you are feeling pretty much back to normal within a few days. Definitely you're going to have some cramping, some bloating, a little bit of bleeding just from where the puncture sites were in the vagina. But again, usually by the next day, people are pretty much back to somewhat normal activity. And within a week, you're back to kind of normal exercise and things like that. And so at that point, you are kind of done with the egg retrieval process. At that point, the eggs are combined with sperm in our laboratory through what we call ICSI, which was the picture on the last page. I'm just seeing it looks like our webinar has stopped for a second. Perfect. I'm just going to bring us back to our next page. So here we are. And so by bringing eggs and sperm together, which is called fertilization, we are able to increase the chances that eggs and sperm come together. Typically about 80% of the eggs and sperm come together kind of for all comers. If you're using an egg donor, that could be a little bit higher. And at this point, these embryos are grown out for the week in our laboratory. At the end of the week, we have what's called a blastocyst embryos, and those are then going to be tested for chromosomes, and then later frozen and done. A transfer will be done. Just to talk a little bit more about the embryo aspect of things, this is definitely the part a lot of people are always loving to see pictures. So just to start, like we said, we have these embryos that are created by putting the eggs and sperm together. And so in this picture, you can see a day 1 embryo, which is an egg and sperm that came together correctly. And then it grows. And so for the first couple of days, they just kind of multiply and divide, and that kind of one cell becomes many, many cells. By day 3, there's about 8 to 12 cells. By day 4, there is more than probably 50 cells, and they're all starting to condense. And by day 5, sometimes day 6, depending on how quick or slow the embryo is growing, at this point, we're hoping to get what's called a blastocyst embryo, which is over 100 cells. And if you see in this picture, there's this part that is the cell mass, the ICM, the inner cell mass. That's going to become the actual fetus. The outside part is going to become the placenta, and this is where we're actually able to do the chromosome testing for you. So a few cells are taken from that outside, which is called the trophectoderm, and you see this blastocyst biopsy picture, and those few cells are then going to be analyzed. So for everyone, we're going to analyze the chromosomes, which is basically your genetic makeup. Normally, for numbered chromosomes, you should have 2 copies of each one. You might have heard of something called trisomy 21, which is Down syndrome. That's an example of an abnormal chromosome embryo that we would be able to detect from this testing. Similar, lots of other types of numbered chromosomes, you can have trisomies or monosomies, but basically by doing this chromosome testing, we're finding all of the normal embryos for you. And by doing that, that's how we're getting such a high success rate. And we're also going to decrease miscarriage rate by over 50%. Additionally, prior to even going through this, we would do a full kind of screen of your history in terms of other types of potential genetic family history. And additionally, a blood test to look for certain types of genetic conditions like cystic fibrosis or sickle cell anemia. And if there's any concern for any of those, we also will check the cells for those specific genetic diseases if needed. Lastly, from doing all of this testing, we will know the gender of each embryo. If that's something you are interested in knowing, we could let you know. Otherwise, we can keep that blinded. And basically, by doing all of this testing, we are finding all of the best normal embryos for you. And then from that, we can pick one to have such a high rate of pregnancy when we do the transfer. Kind of one little caveat is that while we can do a lot of testing, this is great. We really are massively increasing the chance of success, decreasing miscarriage, and really trying to find you healthy embryos, but it can't look for every single possible thing. So we would still have you or your surrogate be going through kind of normal prenatal screening. So just to talk about kind of this whole process, because I know that's a lot of information to put all together in terms of what I like to call our treatment timeline. So first and foremost, we have to make some embryos. So whether that's using your eggs or sometimes depending on history or your kind of specific ovarian reserve or just kind of desires, definitely if that's not going to be your own eggs, it would be an egg donor, and she would go through the same whole timeline. And so that timeline would be just an in-depth history, going through everything, making sure we have all the information to really personalize your protocol. An ultrasound and hormones on the first couple of days of your cycle to see how many eggs we think we could get in an IVF cycle, or like we said, if that was your egg donor. Definitely we need a semen analysis for the male, or we could use donor sperm. For kind of all parties involved, we need checklist blood work, the genetic blood work testing that we discussed. At that point, when we're kind of getting ready to go, we start doing consent forms. You would get injection teaching to learn how to do the injections. And then we actually do that whole IVF cycle we just talked about to make the embryos. And so at the end of all of this, like we said, we have these nice chromosomally normal tested embryos. Those are actually frozen. And so sometimes people are concerned, will freezing an embryo decrease its chance of success? The answer is no. Most studies actually show a frozen embryo has a higher chance of success. Definitely if you were using your own eggs, definitely the concern is that if we were going to put the embryo back into your body, there's just a lot of hormones. And so because of that, we started to freeze. And so by freezing these embryos, we've really found the chances of success is the same, if not better. So we can use this to then talk about using an embryo in the surrogate. So by freezing the embryos, we're able to do the best way of chromosome testing because we can sample at each day. We also then are able to basically freeze the embryos so that we can then really not have to have a perfectly synced cycle between the actual embryo development and the actual transfer. So for many cases for using surrogates, we actually freeze the embryos regardless and then go into a surrogacy cycle. If someone did want to do what's called a fresh transfer, definitely that would be something we could work with you on. But again, at this point in time, typically we freeze all embryos regardless if someone is using it in their own body or a surrogate. So in the midst of all of this, we would be having you work obviously to get a surrogate. And so that would be through obviously Patriots Conceptions. And so they do a great job in finding surrogates and screening surrogates. At the point that we're getting close to a match, at that point, I would meet your surrogate and be able to go through a full history, physical exam, and just really make sure that that surrogate is a good match for you. At that point, once you've been fully matched and you go through all of the whole process, the transfer process is basically a streamlined process where the surrogate, or if you are transferring your own embryo, would be taking hormones basically to get the uterine lining ready to accept the embryo. And at the end of all of that, the transfer procedure is done. That is a very quick procedure. It's about 5 minutes. It's done under ultrasound guidance. And basically you can see the embryo in the fluid basically coming into the uterus. And then at that point, 12 days later, we do our hormone testing to check for your beta-HCG level of the surrogate or yourself. And then at that point, hopefully get some good news. And then in terms of pregnancy monitoring, we monitor usually until about the first 10 weeks of pregnancy. So that's typically about 3 ultrasounds to check. The first one is around 5.5 to 6 weeks to make sure the pregnancy is inside the uterus in the right place. The next one's around 8 weeks to make sure we see a nice strong heartbeat. And then the graduation scan's usually around 10 weeks. And at that point, graduation happens and you go to your obstetrics and gynecologist, and that's where the surrogate would go. And then just to talk a little bit about the impact of COVID-19, because I know that is a definite concern nowadays, obviously. And so in terms of how is COVID-19 treating, kind of affecting treatment. So definitely at this point in time, we are doing very strict screening. So whether it's during the embryo creation process or during the surrogacy process, anytime someone comes here, we do have you get screened. We are on the Hoag campus, so you'll go through the Hoag screening in our lobby, which would be a temperature and questionnaire. As long as everything looks good, at that point, you'd be able to come up to our office. Definitely kind of in this time of COVID-19, just to decrease potential exposures, we are limiting visitors for some visits, but we understand that people obviously want to be involved. And so absolutely for transfers, pregnancy scans, you can bring visitors with you. During this whole point, if you or your surrogate were to actually get COVID-19 or have a very high suspicion for COVID-19, that would be a reason we would cancel a cycle if that was kind of in the beginning during embryo creation or if it was before a transfer. The thought there being is that that definitely could potentially decrease success rates, and we want to obviously have you maximize your success. The great news is that if that's during the embryo creation process or the transfer process, you do take a lot of very costly medications. And so most of the pharmacies nowadays have programs that if you did have a cycle that was stopped and canceled due to a COVID-19 case, at that point, they would actually give you back your medications to get you back to the point where you had stopped previously. So if you were to get COVID-19, like we said, we'd stop your cycle, you would be able to recover, and once you were fully recovered and cleared by your doctor, we could restart the process, whether that was creating embryos or restarting a surrogate's transfer cycle. What if the surrogate, or if you were carrying pregnancy yourself, were to get COVID-19 in pregnancy? That is definitely, obviously, a concern. Really, at this point in time, there has been no definitive data of a specific increased risks to either the person carrying the pregnancy or the pregnancy itself, specifically from COVID-19. That being said, when someone is pregnant and they get very sick and have high fevers, whether that's COVID-19 or the flu or something else, that does unfortunately increase the chance of a miscarriage. But that would be something why we would recommend, if you were to potentially be exposed or be sick, definitely you would want to go directly to a doctor, try to keep your temperatures down as much as possible. But in terms of a specific birth defect or something like that, there's been no definitive data. In terms of the effect of COVID-19 on a pregnancy, in terms of being pregnant and being very sick, definitely there have been cases where pregnant women have gotten sicker than one might have expected. But again, in COVID-19, it's just very kind of still unclear specific data about that. So at this point, there is no reason to not try to get pregnant. We would just recommend taking all precautions. And in terms of what we're doing to try to potentially decrease any potential risk, aspirin, as in baby aspirin, is something we would put as part of the transfer protocol, with the thought being if someone was to be exposed to COVID-19, we do know that that is potentially increasing the risk of blood clots. Those small little blood clots could be a reason why someone would have a miscarriage. And so the hope would be that baby aspirin would help decrease all of those risks. So that being said, COVID-19, it's scary. We don't have, all of the information, but at this point in time, there is no reason to not do treatment or to seek pregnancy. We would just advise all precautions. That would be obviously taking all precautions and social distancing, wearing a mask. Definitely as a pregnant person, the hope would be is possibly if you could get an N95 without taking that away from a healthcare worker, that would be great as well. And then in the small case you were exposed or potentially thought you had COVID-19 in pregnancy, definitely we would recommend seeking medical treatment as soon as possible. But it's been great talking to you. Obviously, I would love to take questions at the end. And so at the end, definitely if you have questions or if you wanted to have a consult specifically about your personal information, absolutely, you can always reach out to us via social media or through our website.
And awesome. And by the way, if you'd like to book a consultation with the Dr. Lisa Beck at Newport Beach, if you're from around there, or you simply like to go onto the website to check her out, I'm gonna go to the center of your screen. There's a button there. Click on book now. That leads you to her appointment page. Yeah. So anybody, if you like to take the opportunity now, you can click on the link book now, and so you can check out Dr. Lisa Beck's profile, and if you're interested, you can book an appointment with her today. And the surrogacy calls at picture conception. I know this is what everybody talk about. This is the part where it gets everybody hesitated. How do I get the money to, what will be the total cost? How do I get the money, or is there any way to finance it? So we're going to talk about that in detail. So a picture conception ranging from 100,000 to 130,000. But that price is only for surrogate from states like California, Nevada, and Oregon, where the demand for surrogates is extremely high. If you're looking outside the state, the tri-states, for example, Arizona, we can you can potentially lower the cost of surrogacy significantly because the demand is simply not as high, and the basic compensation for surrogacy dropped with demand too. Or we have some surrogates on the East Coast, Midwest. They all willing to accept a lower than West Coast compensation. So how the money going to be used during your surrogacy journey? First is a surrogate screening and management, including our own agency fee. And surrogate screening also includes to check their background, their criminal background on county, state, and federal level. A simple pull of their driver record to see if there's any reckless behavior. It doesn't mean a parking ticket fail to stop at stop sign will stop them from doing surrogacy, but we just want to look for any type of recklessness that would deem this person irresponsible. Also, what we also do, we do a soft pull on the credit history to see, and her current credit history to see if she has any outstanding financial debt, because we don't want getting money to be their primary motives. So that's what consists before she moved to medical clearance, she will also need to go to wherever the intended parents of physicians at, for example HRC Newport, to get her full medical physical down, to check if she's and also the psychological screening to make sure she's fit, and that also incurs fees and costs. Legal fees that normally consists of drafting the intended parents, drafting the surrogate contract for the intended parents, and also an independent counsel to represent the surrogate to review the surrogate contract. And the second part of legal fee is in California we call it pre-birth court order. In some states it's pre-birth, in some states it's post-birth to establish your parentage. But either way, that portion constitute the other half of the legal fee. Surrogate benefit package including her base compensation, in addition some miscellaneous monthly allowance to cover her gas, some very basic, her wear and tear of her vehicle, because she needs to travel constantly to her medical appointments. Maternity clothing allowance. There's a housekeeping reimbursable amount. It varies in each different situations. Surrogate insurance fee is another big portion. Fortunately, it's November 1st is fast approaching. So if you're looking to get into surrogates now, it's a good time because during the open enrollment you'll be able to get a very affordable care. Afterwards, it gets more complicated. There's you got several different options, but they're all more expensive. Lloyd's of London is one of the popular choice. There's many products that build around Lloyd's of London products, but in essence, they're still Lloyd's of London, and that cost can go anywhere from 20,000 and up. So we already talked about how we screen our surrogates. We do their criminal background. we do have a full-time registered nurse to screen all her all her medical records and to pre-screen her medical record in accordance with the ESRM GC recommended guidelines. We also have a pretty good surrogate pool online where you do need to sign up before you get to the detailed profile. But if you want to see an overall profile page, here's a good opportunity. You can go to the center of your screen and click on Learn More. That'll lead you up to our surrogate profile overview page. But if you want to see any detailed profile, you need to sign up with us. We do a quick vetting process. Because for intended parents, we want to be responsible for our surrogates too. We do the same kind of screening on your criminal background, your your ability to pay for the surrogate, et cetera, et cetera. So we do have a vetting process before you get to our detailed profile. And after you match, and on our website, once you see somebody that you like to meet, you can give us a few different choices. And then we can provide a detailed profile. Manufacturer decide whether it would be a good match, not just her physical condition, her belief. It's a very quick example is her religious belief. We do have Christian parents in the past that only wanted a Christian surrogate because they want to have that type of they want to have a good long-term relationship. They want to nurture this relationship with their religious belief. So we do have cases where they read the scripture to each other on a daily basis throughout their surrogacy journey. Medical so there are many different factors. So make sure you talk to your client relations thoroughly so we can find the ideal candidates for you to if you live close by, we can set up an in-person interview. But more commonly, we do a Skype or Zoom call where you guys will meet in the video, and after the mesh meeting, of course, you're gonna the surrogate have to be they have to be screened in person. Also, there's a psychological consultation normally done by GSRC group will talk about that in detail. In many cases, there's a secured online platform for you to connect with your psychologist. There's a personality test, and there's the 50 to 60-minute talk with a psychologist to determine if you're mentally fit for the surrogacy journey. And the legal process, and all this can happen very fast. And the legal process, it depends on how many. It depends on how flexible both parties are. There might be a little bit of back and forth in terms of the specific terms and conditions in the contract, but that normally doesn't take more than a month to get down. And after you both parties cleared the legal process, the law firm will forward the clearance letter back to the clinic to start the journey officially. Then the surrogate will get what we call a FET, frozen embryo transfer calendar. Then they will take the medication following that calendar strictly until they get to the transfer day. There are a few appointments here and there to check her, to get the baseline blood work, her uterus, and ultrasound. Then after 10 weeks, so 10 weeks is all she will spend at any IVF clinics. After approximately 10 weeks, we call it graduation from the IVF, and she will go to a normal OBGYN doctor's office and deliver at a normal hospital at the end of her pregnancy term. So and also everybody talk about it. How do I get the money for surrogacy for the surrogacy? One of the before you get to any specialty loan, which we do offer, what you think about it now is the mortgage rate is incredibly low right now. So I think that the best way for you to, if you don't have any cash available, I think the best way for now to take advantage of the current low interest It's a very simple cash-out refinance on your existing mortgage if you have any positive equity. Then, if that's not available to you, we do have several different options for you. Because for the first option, really you spread your payment over 30 years, 15 years. Anyway, long period of time, and you only pay like 2.5% or 2.7%, APR. So that would be the most incredible deal. But if you don't have a private equity, you don't own a home, we do partner with the Personal Health Lending and also the Light Stream with Fund Trust. In which we can finance up to 100,000 with a good term, not as good as mortgage, but still that's something available to you if you don't have if the cash out refinance on your mortgage is not available. And to qualify for that loan, you only need to have a base credit of 720, and then the loan officer will talk to you about the debt to equity, debt to asset ratio to determine if you would qualify for the specialty loan. Okay, and I guess I'll finish my part in regards to surrogacy cost, surrogacy process, and the financial challenges. And also, I want to briefly mention about the COVID-19 before I pass my mic to JSRC Group. What we have done to ensure, so right now, because a lot of demand from the parents, we do offer, free tests, sometimes case by case to our surrogates. We also, we do consultation with our surrogate admission specialist will instill all the safety guidelines in our surrogate test when we do the pre-screening call, when we even before they get admitted to our program. So they've done everything. We haven't seen one single case of COVID-19 ever since the start of the pandemic, and we'll continue to do so to make sure everybody have a safe and sound journey. So okay, that's a bit about the COVID-19 with us, and now I'm gonna pass the mic to JSRC Group, and they're gonna talk to you about the emotional challenges during the surrogacy journey.
Hi, everyone. It's nice to meet you. I'm Jennifer, and this is my partner, Samantha. Hi, everyone. Our slides actually talk to mostly the additional emotional challenges of the journey as it relates to COVID. So we're going to deviate from the slides for a moment, just talk about general emotional challenges as you're going through the journey. We are therapists, and we are always focused.
I think you muted yourself. You muted your microphone. Okay, there you go.
Perfect. Okay, so we work with people going through this process, and we work with intended parents. So our work focuses on relationships. So it focuses on relationships with intended parents. If they're a couple, it works with relationships if it is related to their support system. We focus on relationships between IPs and GCs, and we even help navigate relationships between IPs, GCs, clinics, and agencies if there's some confusion or perhaps some conflict, which we try to avoid before we get there. So as therapists, we're working with people on the fertility journey, and we're also focused on therapy with couples and families even outside of the fertility journey. Some of the components of the fertility journey that we find really important to address, and then we'll turn over to the slides, are, this is a challenging process. And anytime you're dealing with a challenging process, we understand that there is a lot of money invested. We understand that there's a lot of time invested. We understand that expectations have changed. Many of our clients who are going through the fertility process did not envision themselves being here. So what we like to do is work with clients to help deal with these stresses and the challenges that are in particular as a part of the journey are affecting them personally and affecting their relationships. One of the things that we find is that as people are going through the journey, they're very focused on logistics, which is totally understandable. We just heard a lot about the medical components of the journey and the logistics of the journey. But what often gets overlooked is the emotional components of the journey and the ways in which this affects people. And we like to really work with clients to make sure that they're focusing on how they're feeling, some of the things that are affecting their day-to-day, additional stresses related to the journey as it affects their communication, reactions, people may be interacting differently than they usually do. So that's one piece of this. The second piece of this is communication. There is always a lot of question about communication and how to communicate or who to communicate to about this process. And one of the things we like to say is that there's really no right answer to that. Everybody's journey is their individual journey. Choosing to share or not share with people in your lives is something that is important, and it's a personal decision. But we work with clients to talk through that and even enact the kind of conversations that you may want to have with people as you're going through this. So as sort of a background of the types of things we're usually talking about, we're also, we touched on in this conversation, screenings and psychological screening as you're going through the process. One of the things that we're involved with is screenings of donors, screenings of gestational carriers, and also screenings of intended parents. And we often get a lot of questions about what we do in these screenings. And really what we are focused on is seeing 3 steps down the road, understanding that there's communication up front about expectations from the intended parents, as well as expectations of the surrogate about how they want to be communicating throughout and what part of each other's lives people want to be, both during the journey and after the journey. We also work with intended parents on how to communicate with future children about the process in general. It's something that we get a lot of questions about. And we always are keeping an eye on relationships in general with both gestational carriers and their partners and intended parents, and if there's a partner, and really working to help everyone understand what it means to be going through this process and how to take care of your relationships as you're going through it. So that's a little bit about, in general, how therapists are focused with clients during the journey. And I will turn it over to Samantha to talk a little bit more about the specific challenges people are facing right now due to COVID.
Yeah, so unfortunately, COVID has really hit this industry very hard in the sense that at the beginning of the year when everyone was quarantined, ASRM, which is the American Society of Reproductive Medicine, basically said, we don't know what's going on right now. IVF really should shut down for a few weeks until we can figure out what's going on. So I think that put everyone, especially people who are involved in surrogacy, into this state of kind of hysteria because we didn't really know what was going to happen. Thank God, and luckily, IVF clinics were able to open again, and people are happy to be going through the process quite easily. I know that intended parents and surrogates are very worried about the uncertainty of COVID, and right now, as Dr. Beck said, it's perfectly safe to do IVF. So Jennifer and I are confident in counseling our clients that it is okay. Listen to your doctors. They will guide you and they will tell you when it is safe and when it isn't safe. So just listen to your doctor about the clinic's regulations as far as testing is concerned, as far as traveling to the clinic is concerned. And then, of course, listen to your agency as well, as far as, when it's safe to go to have your embryo transfer, et cetera. Of course, we're always taking precautions with wearing your masks. And, as far as pregnant surrogates are concerned, Jennifer and I often get lots of questions from intended parents about, is she safe at work? Are her children safe going to school? So this is where Jen and I come in, and we usually we'll sit and talk to the intended parents, talk to the surrogate, and make sure that there is open lines of communication.
Yeah, I think, and in looking at this list, these are challenges that are new to the process. And this is a journey that has emotional stresses in general. So with this uncertainty and with these shifted guidelines, one of the ways that IPs can help navigate this is to really be communicating with the people that are informed, like their doctors, like their agencies, their clinics, and their OBGYNs, to understand as guidelines shift what that means. What we're finding is that a lot of parents and intended parents, which is understandable, are concerned, and as guidelines shift, they're talking to their GCs about this, which is okay. The issue is that everybody has differing expectations and understandings of what the guidelines are at the time. So as Samantha said, communication is really important. So intended parents communicating with the GCs throughout this is keeping open communication lines going, ensuring that everybody is on the same page about what it means to be safe, because even when we're following CDC guidelines, we all have different expectations of what's okay for each of us, even if we're abiding by guidelines. So communicating becomes even more important. So in understanding the guidelines, and then also communicating your personal expectations as things move forward. So moving on to the next slide.
The next slide, yeah.
Okay, perfect. Great. So why is this harder? So the reason that this is harder is that people feel more out of control. And this is true whether people are going through a journey or not. Intended parents are already feeling out of control when they move into this process. A lot of this is in the hands of the doctors and the labs and things that we all want to have control of, but that we can't. And COVID overlays this additional layer of stress onto things. We can't control the guidelines. We can't control the virus. We can't control when and if a vaccine will come. So that's one element of why it's harder. The other thing that we had touched on is everyone interpreting guidelines differently. Even Samantha and I can have different interpretations of what the guidelines mean. And while we may know that we need to stand or sit a certain distance apart from people that we don't know or wear masks, one or the other of us could feel more comfortable not being sitting outside at a restaurant, and the other one may feel perfectly comfortable doing that. So that's where it becomes really important for intended parents to communicate with GCs about this. The third one is really important, which is more room for trust breakdowns. Where we see things go wrong in the process with IPs and GCs, and this is a question we get from both sides all the time, is when there's a lack of trust. The relationship between intended parents and carriers is a relationship. And any relationship is built on trust and is built on communication. So trust and communication are the most important components of this, with shifting guidelines and with different expectations about what it means to be safe. Communication becomes even more integral. When we're doing screenings at the beginning of this process, we're sure to talk through as many of these things up front as possible. If you're in a screening and these things do not get brought up as related to COVID, it's really important to talk through them, because if you can create some level of expectation about what it means to you to be safe, and also if you can create a baseline for communication that can move forward with you as guidelines shift over the journey, that is incredibly important to the relationship. Sam?
Yeah, I'm going to switch to the next slide for sake of time. We want to leave time for questions. So as Jennifer said, our recommendations are to set expectations up front between the surrogate and the intended parents. Open communication throughout the journey is so important. Discuss the shifting guidelines. Managing reactivity, again, is where we come in. Spending time doing what you enjoy. This is for all parties involved. Keep structure and routine to your life as much as you possibly can. Please do not focus solely on the logistics and the fears of the journey. Create and use a support system. And of course, utilize therapy to help with communication.
And these are tools that help with any relationship. Right now, it's even more important. And when we're dealing with fertility in general, those tools become really important, especially with this overlay of COVID that we're all facing. So that's everything that we have. I think you wanted to open that, correct?
Yeah.
To questions and answers.
Yes, and before I do that, I just want to give everybody the opportunity. If you like to, if you like to book appointments with Jen or Sam or together, go to the center of your screen. If you click on book now, that's their link to, and briefly leave your contact information, and they will contact you in regards to whatever your fertility consultation psychological needs. And Q&A, yeah, we're gonna do a Q&A right now, what we mentioned in the chat box. We live stream the event. Oh, and by the way, I'm sorry if you are on Facebook or YouTube, or unfortunately and WeChat, where we got our largest audiences. You might not be able to do the call to action, but don't worry about it. As long as you sign up with our event, you will get a follow-up email to get all the links to book appointment with us, Dr. Beck, or Dr. Levy or Dr. Schwarm. So without further ado, we're gonna check our questions and to see if we can get some of them answered. I think Dr. Beck already started to answer a question in the chat box. Let me see. Is there anything left unanswered? Let me see the mediator.
Looks like there's the last two questions. It looks like there's a question about choosing gender with IVF. So just to talk a little bit about that, the first part, if someone going into an IVF cycle is interested specifically in one gender, there is something called sperm sorting. Basically, the sperm is what determines the gender. So females have two X chromosomes and males have an X chromosome and the Y chromosome. So from the sperm, if the sperm is carrying either the X, it's going to become a girl. If it's carrying the Y, it's going to become a boy. And the thought is that X chromosomes are a little bit heavier than Y chromosomes. Back in the past, people used to literally do what's called sperm sorting, which would be centrifuging, which is literally separating sperm by weight. This was found to maybe harm the sperm. So HRC has actually come up with a way to have the sperm swim through what we call a gradient. So the heavier ones kind of fall down, which is probably the girls, and the lighter ones kind of stay up, which are the boys. And then if someone is specifically interested in boys or girls, we pick the sperm from the correct area. And from that area, we pick the fastest, best looking sperm. That being said, it maybe increases the chance of picking your kind of specifically preferred gender to kind of a 75%, 25%. Whereas if we just pick normally, which is just under the microscope, it's kind of 50-50. So that's the first part if someone comes to us very specifically in one gender. Otherwise, we don't do that. We just do our normal picking the best ones. And at the end, all of the embryos that get the chromosome testing, we're able to tell you which ones are normal versus abnormal. And then if you're interested, we can tell you which ones are boys versus girls. So then at that point, if someone has a preference, we could then pick the normal boy or pick the normal girl to do the transfer of. So yes, technically we can try to increase the chance of getting one as one part, and then we can definitely pick once we know the results which ones are normal, if you had a preference of a boy versus a girl. And then it looks like we have some more questions coming up. There's a question from Roberto. If we choose to use donor egg, would a fresh donor egg be better? So that's a fantastic question. Really, nowadays, there's two big options. The first option is a fresh egg donor, which would be going through the agency to pick a donor. That definitely gives you probably the most options in that you have a little bit more info sometimes about the donor. That donor has been kind of personally screened through the agency, as well as myself or the doctor you were going through. With that, you typically can get many eggs. And so doing kind of a fresh egg donor definitely has a lot of pros. Kind of the other option would be using a frozen egg bank. That's a little bit newer. There are some studies saying that possibly they could be pretty similar in terms of success rates. As a doctor, though, I still would prefer the fresh egg donation. I think you just get a lot more kind of eggs and options, but both are definitely possible. Just kind of scrolling through, seeing if there's any other specific questions.
And also, I remember Lydia was asking you, Dr. Beck, whether she can offset her cost of doing the IVF by donating her egg. I think what I have for her is that yeah, of course, and a donor egg compensation case by case is, it ranges from, normally 8,000 and up. I think it goes 8,000 and up. It depends on your qualification, your age, your physical condition, your physical conditions, your education level, et cetera, et cetera. But I think this is a minimum compensation. If you are picked and matched with a intended parent as a fresh egg donor, will be 8,000. And if you'd like to apply to be an egg donor, I just did a quick call to action. Click on Learn More. That leads to our egg donor application page, and you will be added to the pool once you finish the application for intended parents to choose from. And we do have an awful lot of questions from let's see if once we finish the portion on this live webinar program, we do have awful lots of questions from WeChat. A lot of them do understand English, because WeChat is like a WhatsApp for Chinese, probably more Facebook Messenger. But anyway, we have 600 some people watching us live. Incredibly, because it's a past midnight, it's early morning in China. But anyway, let's see what other questions they have for us on a live webinar. I have some technical issue. I missed some part of the webinar. Can you give us a cost estimate for twins? Andreas Benils. Andreas, I don't know if this question is specifically for IVF treatment packages or for surrogacy. But Dr. Beck, can you tell her for IVF how much that would cost her?
Well, so for IVF, really, we're going to get all of the eggs that we can if you're doing your own IVF cycle, and create as many embryos as we can. And then whatever we end up with in terms of normal chromosome embryos would be options. I see someone's asking also, can you have twins? So really our recommendation would be one embryo at a time, because it's a good 75+% chance of pregnancy with that one. And any extra good embryos you have would stay stored and frozen. You could use them in the future. If you really strongly wanted to have twins, we could put 2 back in, with the understanding that a twin pregnancy is a little bit of a higher risk pregnancy. But in terms of the cost of that, it would be technically the same cost. It would just be the cost of the IVF cycle, and then just seeing how many embryos you get. In terms of the actual general cost of IVF, definitely there's a lot of factors. Definitely in terms of actual estimates, it really depends if you have any insurance coverage. We do have different promotions and specific discounts for example, Kaiser patients or military patients. So definitely that would be something as part of a consult with me. You also get a financial consult, and so they would go through your insurance and any kind of potential discount that would apply to you. But in terms of a very rough estimate, again, it's hard to really give that, because if you have insurance coverage for the testing or whatnot, or medications, it really changes. But definitely at a consult, our financial advisors would be able to go through that for you. And then just another quick question, because I see it right after, it's asking if donor eggs would look like me, my husband, or another woman. The great news is that's why I really like having a fresh egg donor, because really the agency works with you to really pick somebody, whatever specifically you're looking for. But in terms of looks, definitely you'll get all that information.
Okay, awesome. And I think the next one is it might be for Samantha and Jennifer. It's well, I think it's Roberto. How long the entire therapy will last?
So that's a great question, Roberto. In terms of the actual IVF cycle to create the eggs, once you've done all the testing and everything, that's a little bit, probably less than a month. It's about 2 weeks of injections, the procedure, and then we get the information from the embryology lab at the 1 week mark as to how many embryos, and then a week later with the chromosome testing results. But in terms of what you're actually doing, it's about that good 2 weeks where it's coming in every couple of days for the ultrasounds. If you were using an egg donor, that would just be all updates you'd be getting, and we would just need sperm on the day of egg retrieval. In terms of the actual surrogacy aspect of it, for the transfer cycle, that's probably about 4.5 weeks in terms of all the medications that they're taking to prepare the uterus to get it ready to accept the transfer. So it kind of depends on exactly how we're doing each part, but definitely some people are surprised to hear it could be a couple of months from kind of first coming in, getting all your testing, getting ready to go for the IVF cycle, or getting the egg donor ready to go, and then getting those embryos to then have the surrogate ready to basically carry the pregnancy, or if you were carrying yourself. But definitely I would expect a couple of months from the very beginning of coming for your initial consult to kind of leaving hopefully pregnant. And again, that could be even longer if you're looking for very specific things with an egg donor, or depending on how you got matched with a surrogate.
Awesome. I do get a quick question from the, and there's an awful lot of questions on WeChat, but I think this one specifically, and it's kind of unique for JSRC group. Let me try to translate. So the customer is asking, they understand there are 2 ways to get fresh eggs. It's a known donor, unknown donor from an agency, but he wonders like if he uses like his relative, like a cousin or a cousin's egg from a known donor, what will be the psychological, or what will be the concern down the road if it chooses to use a known egg donor?
When we're working with, it's a good question, because today we actually spoke with someone who is using their sister's eggs. When you're using a known egg donor, using their sister's uterus to be a carrier. But when you're working with a family member, when you choose to have a family member be a part of the journey, or a known donor, just somebody that we always like to make sure, just like we were talking about before, that expectations are set up front. So we want everybody to take into consideration what is going to be communicated, what is going to be communicated to existing partners, or in general, what's going to be communicated about the process and the decision to use a known donor. Moving forward, if there are going to be partners or family members or future children involved, what kind of communication will happen then? We want to be sure everyone is thinking through the implications and feels comfortable with the decision to use somebody who's a known donor versus an anonymous donor. That being said, these days, anonymous donor is an interesting term, because with things like 23andMe and Ancestry, there are ways for all of us to go online and figure out who we're related to. So even when we're working with anonymous egg donors, we always ask the question of if somebody were to find out in the future that your egg was used to help them come into this world, and that child were to reach out to you, how would you feel about that? And that's a similar question that we would use with a known donor. So the questions are becoming more similar, whether it's known or anonymous. With known donors, we also want to make sure that there's no coercion, that everybody is making decisions for the right reasons. That's the types of questions we would ask.
Yes, and that goes for surrogacy as well.
Yep.
Surrogacy with friends or family members.
Yep. We always, with screens, want to be particularly careful about, oftentimes friends or family members want to be helpful, and that is wonderful. We just want to make sure that everybody has asked all of the right questions and thought through all of the implications before it happened, because if 6 years down the road, there are conversations that didn't happen, it's not good for anybody's relationships.
Okay. And another question for you, I think, is for Dr. Beck. That's from WeChat too. I'm sorry you guys weren't able to see it. Let me translate. I wonder, you have mentioned about the benefits of using fresh eggs versus frozen eggs. Wonder, is there any significant differences between in terms of success rate?
So that's a great question, kind of fresh eggs versus frozen eggs. So really kind of overall studies at this point, we say that a frozen egg is similar in terms of success rates to fresh, meaning that once it's thawed, it has similar fertilization, kind of embryo creation, and then actual pregnancy rates. That being said, it definitely depends on the quality of the frozen eggs. There's different egg banks out there, or different ways of getting frozen eggs. So definitely you would want to make sure that's from a high quality egg bank, and that would hopefully then have similar success rates. That being said, definitely some frozen eggs, you hear sometimes slightly lower success rates. And so definitely you would just want to be making sure to go through an accredited place for the frozen eggs. Many of the bigger kind of reputable egg banks do have kind of guarantees on how many embryos you might get. So typically they sell them by cohorts. So you buy one cohort, and from that one cohort, it could be 6 to 8 eggs. They usually guarantee one blastocyst embryo. Where it's just to kind of compare a fresh egg donor. Typically you're getting all of her eggs, unless you might be splitting that cycle, but typically you get 20 plus eggs, and typically we get multiple embryos. So there's definitely just pros and cons in terms of thinking about using one versus the other. Kind of the one other little caveat about the frozen eggs is that most places when we thaw, it's about a 90-ish% successful thaw rate, just because the egg is just one cell. It's a little bit fragile, and so typically not every single egg may survive the thaw. So it's just an understanding that we might lose 1 or 2 of those frozen eggs before we actually get to the point of making embryos. Whereas with a fresh egg donor, all of the eggs are right there. We use them right away. But really, again, in terms of studies, most studies kind of with a reputable egg bank, we say that it's pretty similar. You just might have a little more options with a fresh egg donation cycle.
Awesome. Okay. Yeah, we're having a mediator translating, and thanks for the answer. For WeChat it's a little bit more difficult because of language barrier. Sometimes have to have the mediator to type the interpretation, the translation back to them. And I think it was Gary was asking GSRC, what the therapy, the IP package includes, like if they want ongoing therapy. I think that's what he was asking. I'm sorry, Gary asked. Yeah.
Yeah. So what happens throughout the process? There are different options. So sometimes people come to us in the beginning because they just want to know a little bit about if things come up throughout the process that we're there, and then they work with us on an as needed basis. Some people feel as if they need support throughout, and we do what we call journey support, where we're checking in with both intended parents and GCs and facilitating conversations throughout. And sometimes we work with people on whether it's conflict resolution or just getting through a difficult conversation, or if there's been something that's happened throughout the process medically that they want, if for example, if the cycle doesn't work, which it usually does, but if the cycle doesn't work, sometimes people want support to get through that. So we work with people in all different capacities. It's just like regular therapy, meaning we're going to work with the specific people who are involved, understand why you're there, and figure out some tools to help you move forward in a different way. But we are always looking at those tools, and we're always looking at how to help you when you are done working with us, moving forward in a stronger way than you did when you came in. Yeah, fertility is one of the most emotionally challenging processes that people go through, either as an individual or as a couple, and we are very well versed in things that can come up. So sometimes people just want to be sure that they're thinking through the things that may come up before they get there, because you might be the type of personality to want to know what could be coming down the road. Other people have the capacity to start and get through this and then find themselves feeling like there's a bump in the road and want some help. So it really just varies, but it's very personal and it's very different for everybody. We work with everybody in very different ways, and I'm thinking through my day-to-day, and I think I've had 4 totally different conversations, all related to fertility.
Yeah. Thank you for the question.
And Dr. Beck, there's a follow-up question from the same person asking on WeChat is that okay, he's trying to working out the math, whether frozen or fresh egg will makes more sense. He's just he wonders what under normal circumstances how many eggs were you able to retrieve from a fresh egg donor per cycle.
So that's a great question. So in terms of numbers of eggs, definitely we usually get a lot. If someone has previously cycled before, we actually have a better estimate as to how many they got last time. Hopefully we get similar. If this is their first time cycling, We can, estimate based on how her ultrasound work looks and what her labs look like. But I would say on average, because most egg donors are in their low to mid 20s, we get a good 20 to 30 eggs typically. Not every single egg is going to be a good usable egg. And again, there's a lot of dropout between the eggs and sperm combining and actually becoming embryos. But definitely if you do just your kind of a one fresh egg donation cycle, you usually end up with multiple embryos. Whereas if you're using an egg bank, typically you just buy one small cohort with the thought of just trying to get one embryo. So if you're looking for numbers, definitely just doing a full fresh egg donation cycle, you're going to get a lot more embryos typically.
Awesome. And let's see. I think the next question, I don't know how many more questions you guys have time to take. I think the last one, why don't we just try to wrap up the webinar, it's already exceeded the time, but we try to choose the one last question. Let me see, on the WeChat, I think this is more like relationship related. Matter of fact, let's make it two. The first one is for Dr. Beck. What the audience said is that this might be a conversion because she kind of confused. Like her doctor told her about the 3-day embryo and the 5-day embryo, and she didn't understand fully. What's the reason to choose one versus the other one for transfer. So can you offer detailed explanation, why some clinics suggest that you transfer 3 days, the others are for 5 days?
Sure, so absolutely. So in terms of a day 3 embryo transfer versus like a day 5, which is a blastocyst transfer, definitely specifically here in the United States, really we have moved away from day 3 transfers. I brought the slide back to these pictures of the embryo. So a day 3 embryo only has about 8 to 12 cells. It still has a lot of kind of reproduction to kind of go along. So from day 3 to this day 5 blastocyst, typically about half the embryos are going to stop growing. And so when we look at a day 3 embryo, we don't know as much information about it. Whereas when we look at a day 5 embryo, it's already survived a lot to get to that point of growing to that nice, big, well-formed blastocyst. So we've already discarded probably not as good embryos along the way. So when we talk about a day 3 transfer, we don't know that much about it. The embryo really hasn't proven itself. And so typically we transfer more day 3 embryos with a thought that at least half of those wouldn't have even made it to a day 5 embryo. And with a thought that really chromosome testing on day 3 isn't as accurate. So really for that reason, most kind of high level places have moved away from day 3 transfers. The one person that might be a candidate for that would be someone who we don't think can make a blastocyst embryo. They've tried previous times, and it's really kind of a last resort. Really nowadays, blastocyst transfers is really the standard of care, and with that pre-implantation genetic testing, we do that at the blastocyst stage because we aren't harming the growing embryo because we just take the cells from the outside. So really, if you have the technology and the access, definitely a blastocyst chromosomally normal embryo is what you would really want to be transferring. And because of that, that's why we really now just do single embryo transfers for the most part, because that one normal chromosome embryo has such a high chance. Whereas with a day 3 embryo, you typically need multiple ones of them. There was a question a while ago asking about quadruplets. That could be a case where someone got multiple day 3 embryos transferred and they all actually ended up growing and being normal. But really, again, the standard of care now is typically a chromosomally normal blastocyst embryo transfer.
Okay. And Dr. Beck, while you're speaking, somebody said somebody among our audiences wants to book appointment, so I'm going to send out the link again. So let's suspend for like 10 seconds or so. Yeah, take the chance if you'd like to book appointment with Dr. Beck. And thanks for expressing your interest. And the last question I think I checked for JSRC group is from WeChat. They were asking, let me read the question. So I was I was going through a surrogacy journey. Is it tour? I was going through the surrogacy journey with this agency, but after my surrogate graduated from IVF, all of a sudden she stopped being responsive, so and the agency tried to get a hold of her. She just, it's a very minimum communication. I really, I'm very disappointed. How do I guess it's about a relationship nurturing. How do I, is there anything I can do to, it seemed like when she started to take money, she started to ignore me. So, is there any good solution to, is there any anything I can do to improve the relationship?
That's a good question. It's a hard question without knowing more. It sounds as if perhaps there's resentment because of the relationship being a financial one. Could be one reason. So maybe opening up the lines of communication to ask if there's something specific going on, or to communicate that the relationship as a person is as important as the relationship as a carrier. I think sometimes carriers end up feeling like they went into this and they knew that they were going to get paid to do this. And once they're pregnant, which it sounds like in this case it's after the cycle, and they're released, all of a sudden they feel like it's a financial relationship. So the more intended parents can communicate that there's an interest in who the person is, in addition to being the person that's carrying their baby, that sometimes can help. So asking about what's going on in their life, this goes back to COVID too. There is an additional overlaying layer of anxiety and stress right now that we all are facing. And sometimes people may react, we touched on it in the slide, but not too well. People may react to things that aren't actually the thing they're reacting to. So if the conversation is opened up, it may just be that the carrier's feeling particularly stressed and took it out on the IP.
Children,
or they're
could
feeling,
be home
right.
doing
It could be
homeschool,
anything.
It could be anything.
But opening up the line of communication and showing that the parent cares about the gestational carrier as a person and not just as a uterus, so to speak, can usually help.
Okay, awesome. Okay, that concludes. There are many more questions, and I'm glad that we have a great turnout for this event, especially on the WeChat. Many people stay up. It's almost almost morning time in China with this have this many participants. Thanks for all the passion and encouraging words. And it's a special time, especially when you try to do IVF surrogacy during this challenging pandemic. We appreciate that you participate in today's live webinar event, and we're definitely going to do more. We're going to do more organization we're going to organize more in the future, and stay tuned. Feel free to subscribe to our social media. On the last page, we have Dr. Lisa Beck, JSRC, and our social media, so you can get updated information and news. Thanks again so much, and we look forward to seeing you at our next webinar event.
Great, it was so nice talking to everybody. Thank you.
Thanks.
Thank you, everyone.
Thank you, guys.